Good afternoon, ladies and gentlemen. Many thanks, Professor Basu, for having this particular session that is very important, not only from national or regional perspectives, but also from an international perspective. It's my pleasure to introduce Professor Helen Herrman, who has been the immediate past president of World Psychiatric Association. She has got a lot of credentials that makes her truly an international leader in psychiatry. She has been working as advisor to WHO, and more importantly, work in Australia with the youth program is very important and worth mentioning. One of the great initiatives of Professor Helen Herrman when she was president of WPA was preparing a Lancet Commission report on depression that highlighted a number of areas that require attention, not only at the level of clinical sites, academic or research, but had a long-lasting impact on future policy developments. This is a recorded session by her, and she will be speaking on depression through the lens of public mental health. Can we start Professor Helen Herrman's pre-recorded lecture?
Hello, everyone. I'm Helen Herrman from Origin and the University of Melbourne in Australia, and delighted to be with you today. Just disappointed I can't be with you in person, but I trust you're having a wonderful conference in Chandigarh, the Diamond Jubilee International Conference on Mental Health. So I'm talking today about depression through the lens of public health, with the headline of Time for United Action. So I will talk to you about the formation and the work of the Lancet World Psychiatric Association Commission on Depression that was published in the Lancet Journal in 2022 and is available. The full text and supporting materials are available on the website of the Lancet. And my topics will include preventing and treating depression and illustrating how prevention, for example, is critical to reducing the burden of depression. And we need whole of society engagement for the prevention, advocacy, and the treatment and recovery that are all possible. So the full name of the commission is the Lancet WPA Commission, Time for United Action on Depression. And here are the commissioners. They're a group of 25 invited colleagues from 11 countries. They represent a range of disciplines, including neuroscience, primary care, psychiatry, psychology, economics, public health, and it's a wonderful collegial group and brains trust. And we are grateful to the Lancet Chief Editor, Richard Horton, who inspired the group, and the chief editors that worked with us. And I'd like to acknowledge the funders from the University of Melbourne, the American Foundation for Suicide Prevention, and the Wellcome Trust, and needing support from the Trust and from Harvard Medical School in the USA. And the Wellcome Trust and UNICEF supported 2 young people with lived experience of depression, and they consulted on the recommendations as they were being developed. And 3 organisations helped us in leading consultations on recommendations with people with lived experience. That's United for Mental Health, the Global Mental Health Peer Network, and the WPA Service Users and Carers Advisory Group. So the Commission was set up now 5 years ago, with full of optimism, with the purposes to address a neglected global crisis, to advance understanding of the nature and causes of depression, and to synthesize evidence on prevention and care and identify the knowledge gaps. We felt that clear recommendations on promoting public understanding and prevention and care globally would provoke, we hope, would provoke global action, change minds globally. So we began, in fact, through a public health lens. One of our initial considerations was the comparison between the global burden of ischemic heart disease and depressive disorders over time. So you can see that the age-standardized burden of ischemic heart disease, shown here in red at the top, has declined appreciably over the last 30 years, from 1990 at the left towards 2020. At the same time, the global burden of depression has remained steady. And the difference is, while the decline in the burden, which includes prevalence but also disability, is related to care in terms of ischemic heart disease, it's predominantly related to public health measures, including recommendations on diet and stopping smoking. Whereas with depression, we haven't had the equivalent measures in place. The burden of disability related to depression rises sharply in the second and third decades of life in all world regions, irrespective of the wealth of the country. You can see the low, middle, upper middle, and high income countries in the colours represented there. And this is consistent with the early age of onset of depression compared with other non-communicable diseases. We know that the predominant age of onset of people with depression is in the second and third decades of life. And the disabilities consequent on this related to relationships, related to work and family life, and the capacity to function, that disability contributes to this burden across the life course. So depression and adversity go hand in hand. They're cause and consequence of each other. But we know that depression is much more likely in circumstances of poverty, of violence, of conflict, and discrimination, gender discrimination, and discrimination of all other types. And living in a refugee camp or displaced persons' experience of abuse early in life in particular, or living in a slum, these are all likely to increase the likelihood of depression and worsen its consequences. John Steinbeck talked poignantly about the premature mortality from depression. So this premature mortality is related to suicide as well as to comorbidity. We know that depression is much more common in people living with heart disease, with cancer, with diabetes, as well as with anxiety or substance abuse. Despite all of this, most people with depression, whether they live in high-income countries or low and middle-income countries, still receive no care for depression or inadequate care. So even in the high-income countries shown here in the left, in the blue, the less than half the people with experience of depression receive any form of support, and that's less in the lower and middle income countries. But still, if we talk about adequate combination therapy, only a fraction of those people in either low or middle income countries, are shown in these columns on the right, receive adequate care and treatment. So one of the important curtailing factors is the existence, the stigma of depression, and the myths about depression that contribute to that. That depression is an invention of biomedicine. It's a culture-bound syndrome, or it's a personal failing. But the former Prime Minister of Norway has spoken openly about his experience of depression and the way it does curtail treatment and care across countries, and his wish to contribute to combating stigma. So what are the key messages from this report? Well, the first one is that depression is a common health condition, but it remains poorly recognised and understood. So the 1 year or 12 months prevalence is about 1 in 100 people will, or 5% of people each year will experience depression. Whereas if we look at lifetime risk or lifetime experience, 1 in 5 people is said to experience depression if they live to the age of 75, for example. And it remains poorly recognised and understood. People who haven't experienced it or whose family member hasn't experienced it find it difficult to distinguish depression or understand depression as separate from the ups and downs of normal life. And this contributes greatly, as I'm sure all of you as clinicians would understand. But depression's universal. This again flies in the face of these myths about depression being a modern phenomenon, about it being culture-bound, occurring in some parts of the world and not in other. Over more than 10,000 years, we have indicators from of the experience of symptoms or experiences similar to those of related to depression across cultures and across time. Depression's heterogeneous, so that while low mood and fatigue and sadness are some of the more frequently experienced symptoms and signs of depression, there are people experiencing depression can have no symptoms in common, and some collections of experiences that are more common in some parts of the world than another. So how do we deal with that? So before going on to think about the experience of depression, I want to refer to the next key message, which is related to prevention. That if we want to reduce the burden of depression, as we've done across the world with heart disease, we need to think about a a whole of society intervention, as well as interventions in various settings like families, schools, workplaces, neighbourhoods, and health services. And beyond that to individual and family interventions across the life course. So that we, for instance, in this diagram taken from or adapted from the Commission, that we're looking at the complementarity of approaches at different ecological levels, so different parts of society and community related to the individual. So at the societal level, if we promote gender equity and other forms of racial equity and other forms of remove discrimination of other forms, as well as address poverty. And people talked about universal basic income, for example, as an important intervention for depression. These are some of the interventions that are out of our hands as psychiatrists, but for which we can advocate. And then thinking about the settings of families, intervening to prevent violence, to prevent bullying in schools and promote positive school climate where diversity is recognised and welcomed and relationships are positive. Workplaces where autonomy and violence is promoted and violence and bullying are removed. Neighbourhoods where loneliness is tackled through community centres and other means, and health services where there may be supports for people who've been bereaved or have other life stresses. And then the individual practitioners or social workers or families may recognise when individuals and families are at risk of depression and measures. We have evidence that a range of psychosocial interventions can be effective. But for those with the experience of depression, the experiences of recovery and of the condition and of recovery are unique. So that there are a series of quotes about what it's like to have depression in different parts of the world and people of different ages. The important thing in recovery is to have small funds, as someone in Japan. And I often found myself left behind, a student in India, and then a young person in Brazil saying, I thought people would only understand me if they lived what I was living. Nobody could understand me. And we made a clear recommendation to include formulation in any form of intervention for people with depression, whether in a low resource or a high resource setting at different levels as can be achieved. And that is to, along with diagnosis and it's important to understand the person, to include the life stressors, the family and developmental history, questions about other health conditions, and as well as clinical severity and staging, and the demographic and living arrangements. And a staged approach to care. This is a way of organising some of the heterogeneity of presentation so that people early in the course or people who have less severe and conditions can be given appropriate and proportional treatment and support. So this ranges from prevention at the left to early intervention for people with a range of symptoms and distress and emerging impairment, and people with the first episode disorder, and then moving on to a different range of interventions for people with recurrent depression, persistent depression over time. And these are the sorts of the ways that interventions have been organised. And I realise it's hard to take all this in one slide at the moment, but please go to the website and have a look. But these psychotherapies, for those, say, with subthreshold depression here in the second row, and the red arrow indicating psychotherapies, may be effective. If not, acute treatment for a depressive episode, beginning with psychotherapies, adding in antidepressants if needed, and then continuing that treatment as psychotherapy with or without antidepressants. If the episode is not resolved, then it's possible to augment with combined psychotherapies and antidepressants or other psychotropic medicines. And finally, for those with the minority with persistent depression, the third line treatments, we can add in the neuromodulation therapies. And once remission is attained, to continue treatment for the recommended periods. So closing the care gap requires that we engage people with lived experience. And this can be done for people in all sorts of settings. And even in high income settings, we need to engage communities, people with lived experience, peer workers, and community and primary healthcare workers much more in the work, or trained and supervised by psychiatrists or psychologists. And this collaborative delivery model is a way of organising resources to deliver staged care. And this is an approach to care that's been tried and is evidence-based across many settings in the world, with people with lived experience at the centre, co-designing the formulation and the treatment planning and the care needs, families working with lay counsellors, cross-sector providers, that's people with housing, with education, with welfare, violence prevention, the mental health specialist team advising and being contacted as required, the primary care team supervising a lot of the care. So the prime message really is that the last message is that whole of society's engagement, whole of society engagement is needed to prevent depression and to deliver appropriate care and recovery. And that covers the 4 audiences for this report that I'll just mention further in a moment: the healthcare practitioners, decision makers, researchers, and the general community. So beginning with the last one, let me move on to describe the recommendations. So first of all, for the general community, for people to seek support and care early, to overcome these barriers, we need to all to work towards that, but encourage people to come forward, to talk to their families and themselves, to talk to professionals or others who might give advice. Always remain hopeful, being aware that most people will recover. This is one of the other important messages of the Commission, that most people do recover of course, if we look at people who come into even primary care or specialist care, many of those will have more persistent conditions, but across the whole group, most people recover. Focus care on your own priorities. Ensure that the health professionals are aware, and the health professionals have a major part to play in this, of course, to listen and to become an ally if possible, speak up for societal changes. The health practitioners, be proactive, and we're talking about primary care doctors and people in other parts of healthcare. Be proactive in recognising depression to all of us learn about the diverse presentations and lived experiences, and recognizing that one size doesn't fit all. It's important to listen to the person, co-create the formulation, and personalize the approach, and give priority to this alliance with the person with lived experience and, where appropriate, with the families, and practice this collaborative care to reach these optimal outcomes. Ensure that the practices are established to set up such alliances and to work with them. For researchers, understanding the etiology and nature of depression, of course, is important. Identifying novel prevention targets that range from the social determinants to individual vulnerabilities. And there are some wonderful examples of where the two have worked together, where it's been shown that, for instance, poverty alleviation much more effective where there are other interventions alongside. Design and test therapies that address these early and novel interventions. We've got so little in this whole world compared with other parts of healthcare, cancer or heart disease, and develop precision medicine approaches based on this. And engage, it's important for researchers, as we're more and more aware, to engage people with experience of depression and their families, as well as practitioners and policymakers. And finally, for decision makers, respond to the lived experiences and the science. Invest in equities across the life course. So early life experiences have a profound influence on people across the life course, many of whom overcome these, and but some of whom have less support in doing so. Invest in early intervention and sustained care. Support task sharing and the scaling up of this sharing in the process of collaborative care, particularly with psychosocial interventions, and invest in depression research. So one of the arguments for the policymakers in particular is that investing in prevention and care represents excellent value for money and contributes to attaining several of the United Nations Sustainable Development Goals. And conversely, several of these contribute to the prevention and recovery from depression. So eliminating poverty, hunger, of course, good health and well-being, quality education, gender equality, and so on, including climate action, of course. So the final conclusion is that we need, with whole of society engagement, we can achieve appreciable prevention, treatment, and recovery from depression. But we need that whole of society engagement to do what we know already that we could do. So translating what we know into practice, as well as building the evidence base, are the tasks ahead of us.